And we really do have a fantastic lineup of speakers today who bring a wealth of knowledge between them and experience from different perspectives as well. Our first speaker is going to help set the stage here with the need for a bigger workforce to address maternal mental health, particularly within diverse communities. Then we're going to hear from panelists from 3 local organizations that are working to meet mental health needs right now with some of their creative solutions. Each panelist is going to start off with about 7 minutes to share their insights, and then after that, we will open the floor for a Q&A session, and we'll get some questions and some answers posed to each of our panelists as well. So I'd like to introduce our first speaker this morning. I'm delighted to introduce to you Nalani Thomas, MS. Give a little wave for us. So Nalani is a doctoral student in population health at Arizona State University with a wide-ranging background, including case management for pregnant and parenting teens, and also supporting clinical research trials. We told you we talk a lot about research happening today. Her diverse experiences have given her a unique perspective on healthcare delivery and also the importance of mental health models. The AZ Maternal Health Policy Coalition also worked with Nalani last year to write a policy brief on the need for increased diversity in maternal mental health providers nationwide. So one of the people helping create a framework for everyone to follow. So I'm going to invite Nalani up to the podium here to give a few remarks, and if you would welcome her as she takes the stage as well. Good morning.
Good morning, everyone. Thank you so much for joining, and I appreciate that introduction. It was very, very kind of you. Let's set this up well. All right, so my name is Nalani Thomas, as shared, and I will be presenting on advancing perinatal mental health, looking at policy solutions specifically in Arizona. Next slide. So just to set the stage, so a recent report came out from the Arizona Department of Health Services looking at maternal mental health and substance use related deaths in Arizona between 2016 and 2018. And of those deaths, 48% of those deaths were pregnancy associated and inclusive of maternal mental health and of substance use disorder. Next slide. And then to frame the stage, this is something that is continuing. Even from the recent report that came out earlier in January, we see that now it's at 32.6% of pregnancy-related mortality, which is showing a steady increase and that it's consistently happening in 1/3 of our population. Next slide. Furthermore, 12 out of the 15 counties in Arizona are experiencing greater maternal mental health or substance use related mortality when compared to the number of live births in those counties. And what's important to look at with this image is that all the counties are more of the rural counties in the state. So thinking about the particular risk factors of being in a rural community and how we are able to get our workforce in those areas. Next slide. And then lastly, when we're looking at demographics, is that in Arizona, American Indians and Alaska Natives experience 2 times greater percentage of perinatal mental health related mortality when compared to the number of live births. And even when we're looking at the most recent report as well too, that is also inclusive of African American birthing persons. So it's demonstrating that the rural community, that diverse communities, that this is overall 1/3 of our population or birthing populations are experiencing a mortality related to perinatal mental health. Next slide. And most importantly is that 98% of these mortalities are preventable. 98%. So it's unnecessary mortality that's incurring. Next slide, please. So what are the causes? What are some of the things that might be driving this? In my conversation today, I'll be talking or discussing about the current workforce and the policies here, also looking at workforce availability and diversity, as well as potential policy infrastructures of how we can address the perinatal mental health workforce to increase access to care and utilization. Next slide. All right, you can go to, so looking at the current workforce and policies. Next slide. So according to Mental Health America in their most recent report of 2023, Arizona is ranked 48 out of 50 states plus the District of Columbia in terms of mental health workforce availability. And how that pans out in terms of patient-provider ratio, Arizona has 660 patients to every one behavioral health provider in the state. And this number, I also want to clarify, is across mental health and mental health spectrum in terms of thinking about adults. So it's not just isolated to perinatal mental health, but when we distill it down even further, we can see that that's going to increase. And then when you consider it from the national perspective of where Arizona is, nationally, it's 350 patients per every one provider. And the best state is actually Massachusetts, where it's 140 patients per each provider. And what is also interesting from this report is that they saw among adults with a mental health condition, that almost 64% of those adults did not receive treatment for care. Next slide. So Arizona, what does Arizona look like? So I'm sharing a little bit of the policies that have happened. This is not an exhaustive list, there's definitely more, but just highlighting some of the changes in the last few years. One, I'd love to highlight Postpartum Support International and them creating the first of their kind, the Perinatal Mental Health Certification Program, which is a specialized training, providing care or providing an understanding of how to care for perinatal mental health patients. And what's also phenomenal about this program is that it has support from ADHS, and specifically the ADHS offering full scholarships to rural and diverse providers to be able to get this training. So that's a big win, I would say. Furthermore is when we're thinking about the Medicaid services as well too. So Access, most recently in October 2022, they now reimburse pediatric providers during the postpartum period at visits 1, 2, 4, and 6. And if there is a positive screening, it is required that there's a referral that is steady happening. So there's an additional mechanism, which is we're grateful for in order to capture or not capture, but be able to seek services or at least increase utilization and access to care. Next in April, 2023, Medicaid expansion from 6 weeks to 12 months from the postpartum period. And then lastly, of course, the Arizona Perinatal Psychiatric Access Line, which is specifically a hotline with resources and support for treatment planning for providers who encounter patients with perinatal mental health. Next slide. All right, now looking at the workforce availability and diversity. Next slide. So this is, we got information, or we worked with the Center for Health Information and Research from Arizona State University, and we wanted to understand what does the behavioral health workforce look like, at least for the Medicaid population during the perinatal period. So this is a little dated because it's 2021 claims data, but what we looked at was first the earliest pregnancy claim, and then up to 280 days after that, which shakes out to be around 6 weeks postpartum. And so what we found was, at least you'll see the green, which is Maricopa County, that in 2021, that there was 8 unique behavioral health providers that were seeing patients who were Medicaid eligible or enrolled during the perinatal period. And then all the other states, similar to the image I showed earlier, with the perimeter of the state, more of the rural communities had less than 3 providers, like 3 unique behavioral health providers that were seen during the perinatal period, and with 2 counties that did not have any claims related to a behavioral health provider or behavioral health code. So showing the dearth in terms of availability of providers is kind of just steadily increasing. And then next is highlighting Postpartum Support International. This is from their end of year of 2023, and looking at how ADHS's support and over time, how this has increased the number of individuals with specialized training in more rural communities. So we see from 2021 with more of the early adopters, more concentrated in central Arizona around Maricopa County, and then at least by end of 2023, how that has expanded to more rural counties with providers and being able to see patients who have this certification. Next. So in terms of diversity for Arizona's perinatal mental health workforce, when it comes to the licensing perspective, this is not as available, or information is not as available. And that's a part of my policy recommendation as well, but what we can kind of look to for now, at least nationally, According to the American Psychological Association, 16% of psychologists are from racial and ethnic minority groups, and that's nationally. And of course, that can change from different areas, states. So it's really being able to create or understand what the diversity of our workforce looks like so we can improve it and make things better. Next slide. Okay, policy infrastructure. Next slide again. I wanted to highlight the Policy Center for Maternal Mental Health. And what they do is they produce a report every year looking at the policies at different states as it relates to maternal mental health. And for Arizona, at least for 2024, Arizona got a grade of a C. I'm a student, a C is average. There's still work to be done. We're doing better than others, which we can give ourselves a pat on the back for. But as you can see, the area of opportunity is definitely in screening reimbursement, and something that's also highlighted from the report card is meeting the ratio of patient and providers in the field, at least in terms of behavioral health. Next slide. So before I get into my policy recommendations, I did want to share this piece. And so this is from Law Atlas, which is like a legal epidemiology platform. And since 2020, there has been an influx of racial health equity laws across the nation. Not pictured here, but 26 states passed legislation related to racial health equity. Arizona is not one of them. But what I also wanted to highlight, so anything with blue is a law related to workforce development. Anything with yellow is related to a law requiring implicit bias, cultural competency, or sensitivity training. And then anything in purple is a law related to workforce recruitment and retention. And so what we see is California and Illinois are the only two states that have all three of those policies related to that. Then there's 5 states that have 2 of those 3. And lastly, what I did want to highlight is anything with red are states that have a policy that explicitly prohibit or restrict education or training that addresses health or racial equity. And so, as you can see, these are states that Arizona typically aligns with policy-wise. So just being able to understand the spectrum. So there's Texas, there's Florida, Georgia, seeing how we can use policy as a mechanism in order to reinforce the maternal healthcare workforce and also how we're talking to our policymakers in the state. And I did want to, one unique observation is Florida, which I wanted to point out, which they have a law that explicitly prohibits or restricts addressing health or racial health equity, but they also require implicit bias or cultural competency training. So I don't know how they're working that out in terms of how the law is applied, but I did think that that was an interesting observation. Right. So lastly, in terms of policy recommendations, this is not our exhaustive list, but just more of the higher level of what, next slide. This is not an exhaustive list, but more of just the high level of what we can consider and going from the bottom up. First is looking at a minimum data set requirement when it comes to licensing. And fortunately, this isn't something that we have to make up on the spot. Actually, HRSA has guidelines specifically for how to capture state level data. So not only can we be able to understand or do quality improvement within our state, we'll be able to do better comparisons with other states as well too, especially as we're changing policy over time. Next is being able to develop and implement culturally competent curriculum. Because as we can see, sorry, those are going far. As we can see, like, or from the earlier slides, is that we know that the people that are experiencing perinatal mental health mortality it's us, like, respectfully. It's people of color, it's people in rural communities. So when we're increasing the availability of our workforce, then we want to also make sure that they're trained to understand and be able to provide adequate care. And then lastly is in recruiting and retaining a diverse perinatal mental health workforce. We know that by having a diverse staff, there's research out there about having a diverse staff will increase health outcomes across the board for all patients. And so just showing that there's an opportunity to do this in many ways by increasing availability, increasing diversity of the workforce overall. So next slide. They'll go pretty quickly, is shameless plug of the policy brief that we did nationally. If anyone wants to look at it. And then next slide again, we created a policy or a briefer brief specifically to Arizona. So there's an infographic if you're interested in that, sharing that, taking that to your policymakers. And of course, the last slide is our acknowledgement. Just thank you to everyone that has collaborated with us throughout on this project. Thank you to Jenny Bieber for bringing me in, to Cheer, to Postpartum Support International, to the Center of Rural Health and University of Arizona, just all of these partners that we've worked with to be able to understand this and kind of implement it from a policy perspective and from, the community perspective up. It's been such a joy and a treat. So the last slide is just about how to contact me. Other than that, thank you so much for your time and for listening.
Milani, wonderful insights, contributions. And I want to remind everyone, if you are brainstorming questions as we're hearing the presentations from our panelists, go ahead and write them down because we are going to have the open Q&A session in just moments. We are going to move on to our panel of community organizations working to meet the mental health needs of Arizona families. So first we have Michelle Lacey, if you'll give a wave. Good morning, Michelle. She's an MA, LPC, PMHC. She's a licensed professional counselor and certified perinatal mental health clinician. She's a founding member and executive director of Women's Health Innovations of Arizona, which is an outpatient treatment center specializing in the mental health care needs around pregnancy, postpartum, as well as parenting. Michelle has been a member of Postpartum Support International since 2002 and serves as a state coordinator, a national trainer, and a subject matter expert. She truly is a leader in the field of perinatal mental health, and we are very lucky to have her here today. So I'm going to welcome you up here if you would, let us know how you're utilizing peer support specialists and extending the workforce within your partnerships. So please welcome her up.
Well, thank you so much for having me. Thank you, Jenny, for inviting me to be a part of this. As many of you know, I have such a passion for the importance of access to care and improving the workforce in perinatal mental health, which is why Women's Health Innovations came to be. We saw a need of the focus being on the child, and the parents were sort of left to figure it out. And so that's kind of how we came to be. And then early on, we were able to be a part of a pilot study with the Policy Center for Maternal Mental Health to really look at the use of peers to help bridge the gap, to improve the workforce, and to support parents in a different kind of way. And what we learned from that time, and actually I have to put a plug, Christina is here. She's one of our original peers. She's one of our bilingual peers. She goes to the bedside at 2 hospitals and supports parents in that way. So what we learned at that time was that peers are a significant part of this industry. I come from the substance use treatment world, and we use peers all the time. So we have right now 7 peers on our staff. We have 4 bilingual peers, and we actually have certified peers from the front office to the back office. So anyone that actually interacts with any of our parents that call in is already certified. So we use peers in a lot of different ways. One, they do our intake screenings. So parents aren't going to wait months or weeks or anything. They're going to get in really quickly to talk to someone who gets it. Our peers have lived experience. Our peers are in the communities that we are serving. So they are such a significant part of our team. We also work with our peers also work within our community partnerships, and our community partnerships are so significant in serving parents. We work closely with Fourth Trimester, with PSI, with Hope Women's Center. Our peers provide a bilingual, actually a group in Spanish and in English for a postpartum support group, and then also a parenting group. And those are free services that we really feel passionate about to support the community. Our peers also then will partner with our therapists. And when we have clients that have high needs, because we are limited in our intensive services here in Arizona, we can work really closely with our peers to have support for the parent throughout the week. checking in with them, seeing what they need, finding them resources from the most basic items to them, and just to be parent to parent, eyeball to eyeball, to say, I see you, I get this, like I've been there. This is, and they offer hope because they're in a different position than our clinical staff and like than our therapists are. We also offer, we have a young children's program as well at WHI, and that's because we know that sometimes parents will bring their children in long before they will actually bring themselves in for any kind of support. But we have a peer that also works with our children's program, and they're the first point of contact for the parents that are calling in. So a peer that has also, again, lived it, gone through it, worried about their children, wondering if they were scarring their children for life. Because remember, when a parent is struggling, they're not going to say, I have depression or I have anxiety. They're going to say, I feel like I'm a failure. I'm the worst parent at all. Maybe I made a mistake. And then they're going to feel horribly guilty because they feel that way. And our peers can walk alongside our parents to say, when I was in this position, this is what I experienced, and normalize this experience in a way that our clinicians don't, right? So that part is just so significant. Our goals for the next coming year is to expand our peer support program. We have received a grant to expand our peers to have them in a physician's office. So OBs, primary care. And that way, because you know what happens when a mom is struggling or a parent is struggling, they're handed a card or a brochure, and then the parent's like, okay. We believe in this relational model of treatment, that being in relationship with one another is what's healing. And so when our peers are available in a doctor's office, at the bedside, in a birthing center, and someone is struggling, and we can say, here, I see you. Let's talk this through, and let's connect to our resources. I think that is so significant. So we're really excited to be expanding that in the next year, along with our clinical staff and using our evidence-based treatment for therapy and everything like that. But we really love our peers. That's another great thing. And then our peers provide coaching services, parenting education. So we use them in a very diverse ways. And thankfully, for access, we can bill for our peers, which is really exciting. And then we use grant funding or other funding to support our commercial insurance or underinsured parents. So that's a little bit about our peer support program. I could probably talk about it for days because I'm so thrilled to have it. But Christina is also here at our table, and she can share a little bit about her personal experiences, especially at the bedside, like to hear the stories and the connection at the bedside is so powerful. So thank you so much.
Michelle, thank you. And we do look forward to hearing more about the work you're doing and how we can implement it on a broader level, maybe even. Up next, we also want to recognize Dr. Anjali Lafree. Is it? Lafree, thank you. If you'd give everybody a wave. So she has her PhD and is a CHT as well, joining us with a really impressive background of psychology, multiculturalism, nonprofit leadership. As the commander of development for the Siwapatli Collective, she works to help urban Indigenous families reconnect with ancestral knowledge. Her passion for diversity and her work across various sectors have made her a force for positive change. So we are going to invite you to the podium as well to talk a little bit about your work and also how Siwapatli, the program, supports mental health in our community. Thank you.
I'm more impressed with how you said Siwapatli, to be honest, more than my name. So that was fantastic. Good morning, everyone. As shared, my name is Anjali. And, I want to also add and acknowledge my daughter, my grandson, my roots as well. My mother is Maya from Guatemala, and my father was Afro-Cubano. And so I'm Taino and Arawak. And so that's particularly important for me to know for you all to know who's walking in the room with me, who I represent, and everyone that I'm connected to. And that is one of the first parts, right, of that ancestral revitalization and that connection work that the Siwa Patli Collective does. So Siwa Patli means women's medicine. It is a term in Nahuatl. And some of you know us in one of two ways. You either know us from a birth working place, and that is where we started. We started responding to a call to our executive director, Maria Paracano, and that was 9 years ago now, right? And we were responding to her time of grief and bereavement and also experiencing postpartum challenges. And then some of you know us for the work of our food forest and our food justice and land justice work. One of our newer initiatives or we call them bundles is mental health and integrative wellness. So we are coming into a space of 7 acres of land where we hope to build a food forest, a wellness center, a teaching kitchen, and a storefront. But for those who know us, we are doers. we don't like the word no. It doesn't make sense to us. That's actually my mom's language. It doesn't make sense to me. And a lot of people in the organization run the same way. So we do a lot of things where we just keep building, right? Whether we have the land or not, we're 2 miles down the road. What can we do? Well, we can start our community mental health program. We can do that 2 miles down the road, knowing that we need Circle. We use Circle. It was the beginnings. Our comadrita check-ins were for that birth work piece. And so we're just extending that and widening that and creating the foundation for what will be the community mental health program that will live right 2 miles down the road. So now we have talking circles, both virtually and in person. Excuse me. We have them both in English and Spanish. We also have Wellbriety circles. So if you think about Wellbriety, think about the term sobriety, right? Wellbriety in the most, I don't want to say crude sense, but in the most simplified sense, right? It's a model of sobriety that's often based on 12 steps, but with an indigenous framework, right? Where essentially the values of wellness, right, are taught, practiced, incorporated in the circles. We also on staff, so I'm a psychologist, we have a social worker, we have a social worker in training, right, a student. We have 2 naturopathic physicians, and we have all of our comadres, right, which is essentially a peer support model. In a lot of ways, I feel like we aspire to be like Michelle, right? And sometimes she's certainly a resource for us, right, on the peer support side. We are all supports to one another, right? All of our programs and organizations do things that we all kind of look to one another to emulate. So I wouldn't say that we are doing anything innovative. What we are doing is we're returning to old, right? We are doing what communities have utilized for their mental health for centuries. So the term tonalpaqui, I want to explain that. Where in English or in academic and medical language, we think about it like the fontanelle, right? So the fontanelle, the center of our head, that soft spot of our baby within both Mayan cosmology, Aztec cosmology, that space is called your tonal. And the tonali or the tonal is your energy center, right? It is the part of your body or your body, your soul, your system that aligns your head, your heart, and essentially pick an organ, right? For us, it's the liver. There's some other communities or cultures that would maybe align another organ. But that mental health was a daily alignment of all of those organs in our systems. And we didn't just do that individually. We did that in community. We did that through our connections to land. We did that through our relationships. We did that through introspection and just the way that we walked through our day. And there's so many things that pull us from that ability to align, which is why we need Circle and all of these, right? All of these various support systems, right, that we create. But also, yes, there is place for licensed practitioners and we need that, but also our community and our families were the first line, right, of folks who helped us engage in that alignment. So our comadres, right, and our community are also a big part of also offering that support. Again, whether it's innovative, whether it's old, we know how to do this, right? And so it's being in community that we hope that we're trying to provide some solutions to all the many challenges that all of us face. So I think I'm at time, so I'll pause there.
Dr. Lipbury, thank you so much for that. And finally, we want to introduce Cassandra Strouder, a proud member of the Seminole and Navajo tribes as well. She's 22 years of experience as a prevention expert and ICWA specialist. They've made her a powerful advocate for Indigenous communities, and her work as a case manager, a fitness master trainer, and community coordinator has made a positive impact on many, many lives. So Cassandra, tell us a little bit about how you're helping Indigenous communities in Arizona, please.
Thank you. Good morning. Yeah. Yate Bene. My name is Cassandra. I go by Cass. I'm going to talk about Indigenous wisdom for wellness. Next slide. This is who I am. I'm the little one in the rainbow t-shirt. My oldest sister is in the middle in the wheelchair, and then my middle sister is in the red skirt. My sister in the red skirt and myself, we've dedicated our lives to community health work, mental health, wellness as a whole. The picture up top is the teepee is what in my brain, I identify as home, my first home. This is where we practice ceremony. This is what today's reservations sometimes look like, is trying to balance two worlds, a site-built home and the old ways. Down below in the yellow is some of my community work with prevention. A lot of these children were homeless, already addicted, some of them high scholars, amazing athletes, and all the children in between as far as success looks in a Western view. I took 90 children up the coast of California, and we did culture exchange with other tribes. So we ate fish, we went fishing, we sang songs, we learned different languages. We did a lot. And I learned a lot. So I think that because of me, and I'll get to this soon, the first hippo that named me was my grandmother. She gave me my name, which means the one who joined them in a war. I didn't know what that meant up until recently. Each of us are in internal war, communal war, certain things that we're trying to fight. Right now, I'm currently fighting the good fight. Next slide. This is what I mean by the hippo. So the long walk, understanding how historical trauma influences substance abuse in Indigenous communities. I will be coming up on 7 years sober in December. Thank you. And that hippo right there kind of resembles what my journey's been like. He's a little scarred up and scratched up. It's been a battle. So I heard this story that this little baby hippo was exploring one day, and it got away from its family, it got lost, and eventually it got adopted by a rhinoceros family. And the rhinoceros family took it in, even though they didn't grunt the same. The hippo was a little awkward, but the hippo adjusted. And this is my way of describing what historical trauma looks like for a lot of BIPOC people, Indigenous people. And so as this hippo grew to a teenager, it developed some deep scars on the nose, because when rhinoceros are out of resources, they will shave down the bark of a tree to get the nutrients from it using that horn. But the hippo is not made that way for these constructs, for these ways of survival. And so it had this deep embedded scar on the nose, and that can be illustrated as the trauma inside of our brains at times. Go ahead, next slide. So really, that hippo one day felt something familiar one day, and it ventured away then from the rhinoceros family, and it came in contact with another teenage hippo, and this hippo was making grunt calls to it, which it understood. And so it followed this teenage hippo into a pool of water. And this is what I do, is I gather with all the other stray hippos or communities of people that are yearning for that call, for that language, for that ceremony, for that medicine, for that food, for that dance, for that culture, for that color, for that heart, for that soul, and reconnect with them and invite them and make more accessible to them their hippo pool. so that we can swim naturally and grow and come back to our state of health. Next slide. So we know this timeline, the long walk, 1863 for the Diné people was a long walk to Fort Defiance. A lot of my great grandparents and great grandparents were a part of that. The removal, just that word. Imagine right now if you have families and I came into your home and said, you have 10 minutes to pick a child that you want to stay. And so that's a story that's true for my family lineage, and that's something that's been handed down, unfortunately, for me. To reclaim my heritage, those are both of my children. My oldest is 23. She's studying for her master's in sports psychology, and my son is studying for his master's in mechanical engineering at NAU. I only got my GED. That's as far as I went. I struggled with all the stigmas, and I stand here before you as far as Western culture identifies me as a person who has all the aces. However, I'm also doing the work alongside the people that I serve, and I'm allowing myself to let that shame die. Next slide, because my purpose is to return to where I am. And this is visuals of what I do. I travel the nation. I work heavily on prevention. It looks a lot of different ways. I'm committed to share lived experiences with individuals. And the best way to do it is to walk with somebody and to apply that spirit. But I wanted to share one last thing. The girl in the kayak in the red life jacket right there. She told me one day, she said, thank you. We're not related, but she said, thank you, Auntie. I said, you're welcome. And she said, you have wasiba. And wasiba means you're with spirit. So I encourage all of you to continue with wasiba. Yeah.
Here, I believe they call it goosebumps. In Hawaii, we call it chicken skin. Full of much of what you were saying. So thank you for sharing. We do want to open up to our Q&A this morning. So I invited you to write down some questions that you might have. We do have some microphones available on each of the tables as well that we'll be able to pass down. So I'd like to open the floor first to anybody here. If you have a question that you might like to pose to one of our panelists, just raise your hand. Anybody? Don't be scared. Somebody always has to go first. And I will turn if you have something up as we're discussing and you'd like to learn more as well. And also we will invite you to put something in the chat as well, and Camille can let me know. So is there anybody who has a burning question right at this moment? Okay, what I'm going to do is I will ask a question of the panelists. We'll get us started and warm it up a little bit. So this one is going to be for all of the speakers, and I'll call on you each. But we'd like to know some of the specific barriers that you've encountered when you're trying to implement mental health models of care, particularly in some of the underserved communities. Michelle, I'd like to start with you since you're in a more traditional clinical setting. What would you say are some of the barriers that you've encountered?
Funding. So one of our goals as an organization is that equitable care. And we believe that the person who has all the money in the world and the greatest insurance should, and the person who has no insurance and no money should have the same kind of specialized care around maternal mental health. So in doing so, we have worked really hard to ensure that we're one of the only licensed outpatient treatment centers specializing in maternal mental health that bills access. And that is it's a big undertaking for an organization, for a small organization like ours. But we feel it's so important. I love how you bring your ancestors with you. And I think about that. That's what I was like, what drives that for me? For me, that is my own upbringing. Like my family couldn't afford to pay out of pocket like most families. And so we want to ensure that all parents have the same kind of care, specialized care, right? Because you're not going to go to your primary care physician for your congenital heart defect. But if you're forced to, because you don't have care, you don't have the means to go to the specialist, that's not fair. And so we want to improve that. So one of our so funding is a big thing for us as a barrier,
Mhm.
but we also have a philanthropic side that all of our donations will go toward offsetting those costs. We won't turn a parent away. And that's an unusual thing to find for us.
Well, on the note of funding, then, Nalani, I'm going to come to you. Same question with barriers that you see, but also often funding is factored in when it comes to policy. So how do you see that working and other barriers that you've encountered?
Okay, does this work? All right. From my perspective, especially when we're bringing together policy and the research base when we're thinking about funding, I'm going to align with you and definitely agree. I've found myself looking at least provider network adequacy, especially in terms of like the Medicaid population and how that changes from state to state, how it could be time distance standard, provider patient ratio, but then also thinking about patient provider concordance. This is something that doulas, midwives, a lot of birth workers have been encouraging and really asking for, increasing diversity in the workforce. And largely has gone unheard. As we can see, the diversity is still lacking in terms of the workforce and what that looks like. And from the research perspective, I would say is getting more empirical evidence, which sounds really, I hate that that's how it sounds, because there's this other ethical edge of the necessity of it. That there's this call, this urge that we need to increase the workforce, increase diversity within this workforce. And even just having the qualitative evidence of that, to me, is sufficient. So being able to back that opportunity is where I would take that in terms of policy and research.
So Cass, working kind of directly with our Indigenous communities, what would be some barriers that you've encountered when it comes to implementing mental health models of care?
I would think the cultural mismatch. So Indigenous cultures really are founded on interconnectedness. We have this braided way of being connected to so many different areas, and nature is one of them. And in the Western view, things are very separate and based on reaction a lot of the times as far as decisions and laws are made. Reaction to money, reaction to, bigger, better, faster. And having Indigenous cultures doing both, I think for me specifically, talking from my own experience, it feels confusing at times and it feels stressful to try to balance both. That's a barrier internally. It's also a barrier out in the real world because it makes it awkward to split yourself in half and try to navigate. So if I'm feeling that, I know that a lot of the groups that I'm serving and that all the groups that we're serving here together are facing those things as well. The other thing is gaps in services, access to care. A lot of our Indigenous homes are mixed and barely surviving at times, and just vehicle access. Economically, there's disparity there, and it creates more and more of that narrative of isolation and depression, and it also feeds into more of the mental health disparities. The other thing is stigma. There's still a lot of stigma, and just as I shared, it's not easy to share my faults. It's not easy to share my truths as a person, but I've learned this from other people who have done that. And those are the people that I want to learn from, that have actually walked through it. So I myself am internally trying to erase the stigmas, not just erase them, but do the work, the process work, in order to heal those areas so that I can then be a leader and a true teacher to allow these populations to do the same.
Dr. LaFurry, have you seen some of the same barriers or others that you would point out?
No, I would echo both. And I would say for us, the flavor is one from a funding perspective. We are a small but mighty organization. Recently, someone said this about us, and I agree. We are a medium to large size nonprofit as financially. However, we have a grassroots vibe, right? So folks maybe think that we're a startup org, but we have often been fiscal agents for other organizations. So that comes down to when we are meeting with funders or specifically municipalities, this feeling that we do not have the capacity to either manage the funding or execute what we have already done. And no shade to all of the municipalities. We have great relationships with folks, but the work we've done often echoes what the Maricopa County does, what ADHS does, what other institutions do for the sliver of service that we're trying to provide. So in essence, give us the land, give us the money, because we can execute and we are executing so that we can have that sovereignty, right? To be able to enact the programs that we know our communities need and want, and that they share with us from the 1,500 person community needs assessment in South Phoenix, right? The other portion too, I think a more local challenge is terms and identity, right? So folks maybe have a small vision of what indigeneity means. Most of the folks in the collective are from what we would call Southern tribes. So we don't have tribal recognition in the United States, right? None of the tribes that I mentioned have tribal recognition. It is not a competition. It is not shade. It's just true. So what happens is that's why we're a nonprofit. We provide services and support for communities who maybe aren't recognized or perpetual guests. And so being able to offer services for folks, the question that we're often asked is, do I count? Am I Indigenous, right? Can I attend? Everybody can attend. The definition is that you want to reconnect to your ancestors, right? That you want to connect to your homelands and your cultural ways. So that's just, I think that all of us have limited thinking where we only listen for one definition or one identity piece, and then we want to lock somebody into that box. This is what you are. No, many of us have many identity pieces that are more interconnected, but we count ourselves out or feel that we can't participate in this organization, sometimes often for good reasons, because we don't want to appropriate, we don't want to take up space where we shouldn't. But no, please, everybody is welcome to participate in the work that we offer and the services that we offer to community.
There are so many rich conversations to be had within this, but we want to make sure that we keep our day on time and give everybody a break. So I would invite everybody who's been listening, if there is a way, because this is all about collaboration, new partnerships, that if you've heard something that you want to learn more about, or you think you can connect with them, we invite you to step up and have those conversations while we have this next break as well. We also have the Whova app that we had everybody register on. Join those boards and panels. Let's keep this going, and let's talk more about how to take some of the cultural practices that you've seen and how can we implement that on a broader healthcare system. And so I invite you to share those conversations among yourselves while we do take this next break. We also want to remind you that we have a raffle going on, so you can go check that out as well. For those of us in person as well, and online, our next session begins at 11 o'clock. So we've got about 10 minutes, and that will be how social determinants of health impact maternal mortality in Arizona. So please stretch your legs, keep the conversation going, and we'll see you back at the next session for 11. Thank you to our panelists. Can we get a round of applause for that?